Okay, good morning everyone. My name is Dr. Ahmed D. Abdulwahab. I am a diagnostic and interventional radiologist in the Department of Radiology in Razgari Teaching Hospital in Erbil, Iraq. Today we have a nice and common daily tip. We will talk about enchondroma. Enchondroma is a benign bone tumor. It's fairly common, usually seen between the ages of 10 to 30, 35 years old, and about 50% of them usually occurs in the small bones of the hands and feet. If can, like you see here on this diagram, these are the most common sites. About 50% of them occurs in the bones of hands and feet, while the rest of them are distributed between the long bones of the upper and lower limbs. Sometimes it can occur in other areas, for example, in the ribs. These tumors in the small bones of the hand, these are the most common site of for enchondroma, occur in this frequency in the proximal phalanges about 40 to 50%, and in the metacarpals about 30%, and so on and so forth. It's a benign bone tumor. That means it has the features of benign lesions. Usually it is intramedullary, it is well defined, it has a narrow zone of transition. It might cause some cortical expansion and remodeling, but no signs of cortical destruction or invasion unless there is a pathological fracture. Most of the times it is discovered as an incidental finding during imaging for other uh, reasons. Sometimes it's discovered due to pathological fracture, it might cause pathological fracture. Usually it is rounded, intramedullary, well defined, with a narrow zone of transition, and it might have some cartilaginous type of calcification like rings and arcs. Okay, for example, in this case, you can see there is a lesion seen here in the proximal phalanx of the middle finger. It is intramedullary. It is well defined, very well defined, and has a narrow zone of transition. Okay, and if we take other view for the lesion, you can notice here that there is a fracture in the dorsal aspect. So in this case, it is an enchondroma presented by a pathological fracture. The same case, the same previous case, you can see some cortical interruption. It is not due to malignant lesion. However, rarely, enchondroma can transform into a low-grade chondrocarcinoma. Low-grade chondrocarcinoma, it can transform into a low-grade chondrocarcinoma, and this is very difficult to distinguish from a benign enchondroma. So, in cases of pain in an enchondroma with no signs of pathological fracture, low-grade chondrocarcinoma should be suspected. Keep that in mind. Another example of an enchondroma in the proximal phalanx of the index finger, and you can appreciate that it is uh, well defined. It's intramedullary, it has a narrow zone of transition, and it has a cartilaginous type of calcification, that is rings and arcs. Magnified view of the same lesion, you can see it here. It is obviously well defined. Usually it can cause some expansion or remodeling. On MRI images, enchondroma can present as usual cartilaginous tumor appearance. That is, it is hypo to iso intense on T1 weighted images and hyper intense on T2 weighted images. Calcification might be seen as small tiny dots of hypointensity if they are present, and usually it is not surrounded by bone marrow edema unless there is a pathological fracture or some sort of malignant transformation, and contrast enhancement can be variable. So, for example, in this case of uh, T1 weighted sagittal image of the ankle, you can see there is a well-defined lesion with little bit lobulated outline that is seen in the metaphysis of the tibia. And by the way, usually enchondroma seen at the metaphyseal region, and due to the growth of the bone, it thought that it can migrate centrally into the diaphyseal region of the bone. So the most common location is you see it either metaphyseal or in the diaphysis. Very, very rarely you see it in the epiphyseal region, and if you see it in the epiphyseal region, think of chondrosarcoma rather than enchondroma. So this is the T1 weighted image, and you can see it is relatively iso-intense to the muscle with a well-defined region and few tiny dots of calcification that appears as a hypo-intense areas. On this T2 weighted image, you can see that it's hyper-intense with the dots of hypointensity representing the calcification. It's in the metaphysis reaching to the epiphyseal plate. On this fat-saturated image, you can see it is obviously mildly hyperintense with no surrounding edema, indicating no pathologic fracture and no malignant transformation. In the axial view, you can obviously appreciate that it is intramedullary, okay, with intact overlying bony cortex. Again here, the same findings. This is a CT scan of the distal femur showing a large enchondroma occupying most of the metaphyseal region, reaching to the almost proximal diaphyseal region of the bone and showing multiple benign cartilaginous type calcification, that is rings and arcs as we said before, and there is no signs of cortical destruction with narrow zone of transition indicating an enchondroma. The same lesion in sagittal reconstructed images. An example of enchondroma in the humerus, you can see it like we said previously, it is well defined, it is in the metaphyseal region, it contains some dots of hypo-intensity representing calcification, no surrounding edema, intact overlying bony cortex. Again, you can see it here, the same lesion on the T1 weighted image, it's iso-intense to the muscle. What about here? In this chest x-ray, can you identify any abnormality? Well, I think it's quite obvious here in the metaphysis of the right humerus. You can see the enchondroma that appears in the metaphysis, well-defined cartilaginous type of calcification, and you can appreciate the benign nature of the lesion. On the bone scan images, enchondroma usually retain radioactive isotope, as in this case you can see on the left side there is a lesion that is retaining radioactive isotope consistent with an enchondroma. In the foot, the same appearance of enchondroma in the hand as seen in the foot. It is in the diaphysis and proximal metaphysis of the proximal phalanx of the second toe. It is expansile, no bony destruction, narrow zone of transition with cartilaginous type calcification. Again, you can see this here is the main differential diagnosis of enchondroma. When you see enchondroma, what other kinds of differential diagnosis that might look the same? In this case, it is bone infarction. Bone infarction, you can see it is a little bit irregular outline, undulating line, and the line appears as hypo-intense periphery and hyper-intense centrally. Okay, there is usually a causative agent for the bone infarct, for example, trauma or infection or blood dyscrasias or things like that. So you should keep in mind possibility of bone infarction as a differential diagnosis of enchondroma. One other thing to know about enchondroma is that it can be seen as multiple enchondroma, especially in younger age group, like around 5, 6, 7 years old, and this is called Ollier's disease. So Ollier's disease is basically multiple enchondromatosis, okay? And the other thing is that when you see enchondromas plus hemangiomas, That's called Maffucci syndrome. So Maffucci syndrome is enchondroma with hemangioma. And how do we see hemangiomas? We see them by seeing multiple calcified phleboliths within the soft tissues. So multiple enchondromatosis is Ollier's disease, and enchondroma plus hemangioma is Maffucci syndrome. This was the daily tip of today. Thank you. See you later.